Bismillah ar-Rahman ar-Rahim. Thank you, chairpersons. I would like to thank the organizing committee, the Professor Ahmed Gamal, Professor Amira Abou, and the members of the organizing committee for inviting me. I am going to give a talk about pustular psoriasis, updated. I will remind you of the types of pustular psoriasis. We have generalized pustular psoriasis, or von Busch, and variants of the generalized pustular psoriasis. The annular pustular psoriasis, which is sometimes termed subacute generalized pustular psoriasis of pregnancy, with the old term impetigo herpetiformis, and infantile and juvenile pustular psoriasis. I would like to point that pustular psoriasis of pregnancy and infantile psoriasis, pustular psoriasis, are frequently annular. They give annular configurations. We have also the exanthematic pustular psoriasis, acute generalized exanthematous pustulosis overlap. We have this condition, acute generalized exanthematous pustulosis is a drug-induced condition. It's very similar to pustular psoriasis, and sometimes we have difficulty differentiating between them. We have overlap pictures. We have sometimes cases which we can't diagnose as exanthematic pustulitis, and we may mix them with the pustular psoriasis. Well, these are the cases of acute generalized pustular psoriasis. And these conditions, the patient is extremely ill. He has patches of erythema, which become confluent and show small pustules that can be confluent into lakes of pus. And these patients have marked abnormalities in the laboratory findings. There may be hypocalcemia, maybe reduced albumin, neutrophilia, and sometimes oligemia. Sometimes these cases show annular lesions. These are the annular type. The annular type of pustular psoriasis is sometimes mistaken for other sarcinoid lesions. As you see here, on the left side, this can be mistaken for example, erythema annularis centrifusion. These cases of annular pustular psoriasis are less acute than the acute generalized pustular psoriasis of von Busch. In the infantile and juvenile pustular psoriasis are frequently annular in shape. And here is one of my private cases of generalized exanthematous pustulosis, which was due to an antibiotic, erythromycin, and also acetaminophen, paramol or paracetamol. And it was very difficult to differentiate from pustular psoriasis, but I will call your attention that the small pustules are tiny, in this case, tiny pustules, and there is marked edema of the face and limbs and hands especially, and marked exfoliation also. And this patient recovered completely in 2 days after stopping the irresponsible drugs. Here is the localized pustular psoriasis, the palmoplantar pustulosis, and the acrodermatitis continua of Aleppo. This is the picture, pathological picture of psoriasis. On the left side, the plaque psoriasis, psoriasis vulgaris, with irregular acanthosis, and on the right side, the pustular psoriasis with spongiform pustules. Generalized versus localized pustular psoriasis. This was published by one author to differentiate between generalized psoriasis and localized pustular psoriasis. The generalized pustular psoriasis has the youngest age which is recorded, about 31 years. As regards the association with plaque psoriasis, the generalized pustular psoriasis is frequently associated with plaque psoriasis, psoriasis vulgaris, in up to 65% of cases. But the palmoplantar pustular psoriasis is associated with plaque psoriasis only in about 16% of cases. And the acrodermatitis continua of Aleppo is associated with plaque psoriasis in 46% of cases. I would like to draw your attention to the fact that palmoplantar pustular psoriasis has a risk factor, female gender, and smoking. Now, pustular psoriasis versus plaque psoriasis, same or different diseases. Now, we know that patients with pustular psoriasis frequently have lesions of plaque psoriasis or give a history of plaque psoriasis. This is more in generalized pustular psoriasis and less in acrodermatitis continua and least in palmoplantar pustulosis. However, recently, pustular psoriasis and plaque psoriasis have been considered as separate entities. Pustular psoriasis is regarded as an autoinflammatory keratinization disorder. That's to say, inflammation is dependent on exaggerated response of the innate immune system, while plaque psoriasis is a non-autoinflammatory disease where inflammation is dependent on activation of the adaptive immune system. يعني بيتقال دلوقتي انه الباستور psoriasis نوع من الاوتو انفلاماتوري ديزيزز زي مثلا الفاميليال ميديترينيان فيفر، ماكرويل syndrome, and so on. Here is a recent concept. Pustular psoriasis is an auto-inflammatory keratinization disease. What is the rationale of this concept? يعني ايه اللي خلى الناس تفكر انه ممكن pustular psoriasis تبقى auto-inflammatory keratinization disease? The rationale is that generalized pustular eruptions simulating psoriasis may occur as components of certain monogenic autoinflammatory disorders. For example, DIRA. This is deficiency of interleukin-1 receptor antagonist, which will lead to increased signaling through the interleukin-1 receptor. And it is manifested by oral lesions, pustulosis, painful joint swelling, periosteal and osteolytic lesions. There is also the Sappho syndrome, which shows synovitis, acne, palmoplantar pustulosis, hyperostosis, and osteitis in the chest wall. This is a picture of DIRA, as you see, pustular lesions, epiphyseal inflammation with swelling, and we have the osteolytic lesions on the ribs. The ribs show enlargement of the anterior ends of the ribs, and we have cysts, osteolytic cysts in the long bones. we can say that autoinflammation in pustular psoriasis is related to exaggerated signaling by the interleukin 36 receptor due to deficiency of its antagonist. يعني الأبحاث لما فكروا إن ده ممكن يكون autoinflammation وعملوا الأبحاث بتاعتهم لقوا إنه المشكلة في الانترلوكين 36 receptor antagonist deficiency. The interleukin 36 cytokine family is a subtype of interleukin 1 superfamily, and it includes interleukin 36 alpha, beta, and gamma, the interleukin 36 receptor, and of course the interleukin 36 receptor antagonist. Now, the interleukin 36 receptor is expressed on various cells: dendritic cells, macrophages, keratinocytes, T cells, and neutrophils. And the gene which encodes the antagonist, the interleukin 36 receptor antagonist, is encoded by the interleukin 36 RN gene. So this is a gene which is important, and we are going to point to it in the remaining part of the lecture. Here is a keratinocyte, and its interleukin 36 receptor. And this receptor can be activated by interleukin 36 alpha, beta, and gamma, but there is the antagonist of the receptor, interleukin 36 receptor antagonist, which prevents overstimulation of this receptor. Now, when there is gene mutation, the antagonist will be deficient or absent. And so, the interleukin 36 alpha, beta, and gamma cytokines will activate or act on the receptor and will lead to the expression of these cytokines: interleukin 1 beta, interleukin 18, interleukin 8, CXCL8, and CXCL1, CXCL2, and this will lead to recruitment and activation of many cells. This gene can be homogeneous, homozygous, compound heterozygous, or single heterozygous. Most commonly, it is homozygous or compound heterozygous. Now, if we look to this picture, this diagram, these cases of pustular psoriasis, in 65%, they are associated with plaque psoriasis, and in 35% without plaque psoriasis. The gene mutation occurs in more than 80% of cases of pustular psoriasis without plaque psoriasis, and only in few cases, or it is rare, in cases of pustular psoriasis with plaque psoriasis, giving an overall incidence of mutation of 23 to 37%. But here, as I am showing you, the mutation is in most cases of pustular psoriasis without plaque psoriasis. Now, what is the significance of this? Generalized pustular psoriasis is pathogenetically distinct from plaque psoriasis. And this gene mutation has been linked to early onset disease. So we have to investigate the early cases for this gene mutation. And it is also linked with severe cutaneous and systemic inflammation and with lack of plaque lesions. Gene mutation is less frequent in localized pustular psoriasis. 18% in active dermatitis continua of Abou and 6.2% in palmoplantar pustulosis. But I also would like to remind you that some normal subjects have this gene mutation, so that environmental factors are important for clinical disease expression. Pustular psoriasis without interleukin-36 gene mutation has been linked to CARD14 and AP1S3, caspase activating recruitment domain, and adaptor protein complex 1 sigma 3. These are the dominating cytokines in generalized pustular psoriasis and plaque psoriasis. They are different. In generalized pustular psoriasis, there is overexpression of interleukin-1 beta, interleukin-36 alpha, interleukin-36 gamma, and it is rare expression in plaque psoriasis. Also, the CXCL1, 2, and 8 are overexpressed in generalized pustular psoriasis and rarely expressed in plaque psoriasis. On the other hand, interleukin-17, tumor necrosis factor alpha, and interferons are expressed in both conditions, but most likely in the in the generalized pustular psoriasis than in the plaque psoriasis. This is a recent finding. Novel cytokines expressed in generalized pustular psoriasis that are not detected in plaque psoriasis. The 6-domain transmembrane epithelial antigen of the prostate 1 and 2. Now, treatment of generalized pustular psoriasis. There is no universally accepted or approved drugs or guidelines which are specific for pustular psoriasis because it is a remitting, relapsing, rare disease. It is remitting and relapsing ما نقدرش يعني يعني نتابع الحالات بسهولة. And it is rare disease so that there is no blind randomized clinical trials. And there are treatment options. The current treatment, topical therapy, almost always adjunctive to systemic therapy. Corticosteroids, calcipotriene, calcium inhibitors, tacrolimus or primicronus, and PUVA, not for acute forms. The current systemic therapy includes acetylcholine. Cyclosporin has a good response, has a rapid effect for acute disease, and methotrexate has a slow onset of action. But these are the first-line treatment. The second line, the tumor necrosis factor inhibitors, infliximab, also has a rapid effect, but not for acute cases. And for example, it is the Remicade. Adalimumab, Humira, etanercept, but there is a paradoxical effect reported, especially with patients with inflammatory bowel disease and rheumatoid arthritis, if these are associated with psoriasis. And oral corticosteroids, if other lines are not possible, and there must be a caution in their use with very gradual withdrawal. And we are obliged, or we have to use these drugs in pregnancy. Drugs proposed in case reports or small open trials, biologicals, anti-interleukin 17 and anti-interleukin 12-23 and anti-interleukin 23, anti-interleukin 1 receptor antagonist, anakinra, anti-interleukin 1 beta, canakinumab, anti-interleukin 1 givokizumab, dapsone, apremilast, and granulocyte monocyte apheresis. These have been reported to be successful in case reports and small open trials. Drugs which are still in early development is the interleukin-36 antagonist. Pustular psoriasis with pregnancy is treated by cyclosporin. There is no more increased side effects in pregnancy than in the general population, but not used while breastfeeding. Oral corticosteroids with very gradual withdrawal, and infliximab also has a rapid onset but should not be used after 30 weeks of gestation because it can pass to the fetus. Topical corticosteroids and narrowband UVB. So to conclude, the various types of pustular psoriasis are now considered as autoinflammatory disorders, different from psoriasis vulgaris, and dependent chiefly on hyperactivity of the innate immune system. Standard systemic therapies include acitretin, cyclosporin, and methotrexate. Although there are reports of successful treatment by biologicals, their long-term safety profile has yet to be determined. Potential future therapy would be targeted to interleukin-36 and other interleukins. And thank you very much.